Okay, it's working now. So I'm going to need 1 minute. So I'm just going to start off camera. I'm going to grab some water and I'll be right back.
Okay.
Hello. I'm trying to
Hello.
make Asif's life a little easier when he does the editing. So I think because I think that mirror is going to be a problem. Um, so let's see. That'll work. Get stuff out of the frame. Right. One thing I don't like about this setup on Zoom is like you can't really tell if anyone's out there. I don't know if you can see people on.
I've I've logged in through Substack and I'm the only one.
Yeah.
But I could see you clearly. Yes.
Okay, you can. Oh, perfect. Good. Can you hear me?
I can. You're clear.
Perfect. All right. Probably because it's so late right here. Um, if you just keep an eye out, I'm just like setting up a couple things over on my side. I mean, we'll do it regardless, unless you need to go, just to get the content.
Yeah, you have a few people from Substack joining.
Okay, good. Give it like a few minutes. Um, my I let my daughter like do my nails this weekend. And so I have like these ridiculous nails that make everything so hard.
Are they press on or
Yeah, just press. I love I love me some press on nails. Because with my job, like I mean, I can't have nail like it's not even worth like the money and the
right?
like time because I can't I can't like, obviously I can't like operate and do exams and stuff with these nails. So they're
Mm-hmm.
very impractical, but they're nice. You like them? Do you
Oh,
see
they
them?
have, yeah, that's nice.
They're very they're very like sharp at the end. Um,
I don't know what shape you call that. Coffin, I think. I think like coffin shape.
um it's a good excuse not to change diapers though. So
Right.
I'm like, oh, I don't want to scratch the baby. Sorry, Eddie. Like I don't want to scratch him. Um, hmm. All right, so we're gonna go ahead and get started. I have a couple of visuals. We'll see if I can load them up here. Um, let's see. Right. Okay. Oh, this is where you put the files. All right, I'm slowly getting there. All right. All right. So let's see. Let's see if you can see me and the slides or the visuals. One day I'll figure this out. All right. Let me know what you're able to see, like if you can see the visuals. I'm going to put it on to see if it works. Can you see the visuals?
I cannot.
You can't? Okay.
No.
I'm going to try one thing and then I'm giving up. Okay, one second. I think this is it. Yes. Do you see this?
Yes, I can see this.
Okay. All right. Perfect. Perfect. We're getting there. We're getting there. All right. I'm going to go back to just my face for a minute. It's been a while since I've done this. I feel kind of like out of sorts a little bit. Um, how often do you go live on your channel?
Not much. Not as often as I should. But
Uh,
it changes. Like I feel like every week something changes. So I just
what,
kind of
like the
like,
feature? Like the features?
yeah,
Like, do you mean like how Substack is functioning or like the world is
just
changing?
just Substack in general. I
Okay.
mean, they don't really announce changes. You just have to stumble upon them. So that's how
Yeah.
I've been trying to figure out everything is by playing around. But
Well, they seem like they're growing a lot.
they are. They are.
Yeah. So hopefully we got in before it got too popular. Hello, everyone. So today we're going to be doing something special. We are doing our inaugural Labora Rounds Live, and I will explain what this is. It's been a while since we've gone live, and it's nice to see everyone. I can't actually see if there are people there. Are there people there?
Yes, there are people.
Okay, all right. Um, we didn't really, we probably should have talked about this, like what you want to do. So you stop me, like I have my like spiel, but you stop me, if you want to like ask questions about it, or do you have like a sense?
I mean, I can. I mean, as people come in, if they have any questions, I can kind of regurgitate those questions to you if as people join.
Okay.
Um, but yeah, I always have questions.
Okay. I love it. I mean, I think it makes it so much more interesting than just like hearing me just go on and on.
Right.
Um, So, this is a very important moment for our team, for the community we serve, and for the work that so many of you all do every day. If you've noticed, we've been really busy. Still, I want to put like an under construction sign on everything because our profile looks a little bit of a hot mess. But we are actively like rebranding, trying out some new things. Um, and all of this is because we are, finally uniting the three subsects into what the ultimate vision was, which is the formation of the Labora Collective. Um, so, what is the Labora Collective? This, uh, you some of you in the audience may or may not know, but what kind of brings us together is an organization company called Diosara. We are a women's health company that is focused around improving obstetrical and gynecological outcomes for Black women and other women of color. And we do that by focusing in on obstetrical emergencies. But our medical model sits within a medical community because we think it's very important that, you know, so much of health is dictated by everything external to the medical system. And so in our opinion, you can't really take good care of patients if you stay in your ivory tower. It just doesn't work. And I think our medical establishment is a testament to that. We spend a whole lot of money without really good outcomes. And in the maternal mortality space and maternal well-being, women's health in general, we're really lagging behind. So this is one way that we can contribute to combating that. And so we know that the reproductive and maternal health landscape is changing at breakneck speed. Literally, it's like the law, I mean, from a legal perspective, but also the way that the law intersects with medicine, it's it's overwhelming, to say the least. And this puts a lot of pressure on birth workers, so clinicians, doula, midwives, nurses, public health teams, policy advocates, like they're carrying the weight of this entire system. And we built Labor around to try to help meet the realities that we're all facing. And so, what is Labor Rounds? So, this is our series where we will help share some of the insights that we're gathering because we're constantly doing this research. So every week we'll provide deep dives across 10 domains and then also a digest. And all these domains are relevant to women's health. But we look at women's health like broadly. And so, yes, of course, we're looking at reproductive rights and like kind of the legal landscape, but we also look at the economy. We also look at innovation. We look at what's happening in the research space. We have a research domain focused on immigration, just because so many of our so many of our members, so many of people in our community are being impacted by what's happening. And so we want to make sure that we're providing the highest quality information so that birth workers can help take the best care of their patients. Um, so you all might have noticed we're also, during our launch week, we're kind of trialing this Black Friday campaign. And so the way the Labora Collective works is it's designed to be like three ecosystems in one. So you have the blueprint. That's where we house our innovation and our professional material. So this is designed for other birth workers, clinicians, people taking care of patients, advocates. We try to provide, professional tools and insights. The second kind of pillar is women's health, empowered care, informed choices. That's where the medicine lives. We have, several subjournals that are focused around, bread and butter, obstetrics and gynecology, but also going into things like parenting, and sexual health, because again, we recognize that women live complex and full lives, and we want to make sure that what we're providing reflects that. And then the last is In Her Name, exposing the cost of control. This is kind of our experimental zone. We do some fiction writing. We have a couple of things, queued up to come out sometime this month, or maybe early next month, in the fiction space, because we are trying to play around with different ways that we can educate people on medicine. Um, you know, we, like everyone else, has to compete in this like really, dense media landscape where sensationalism kind of rules the day. And so we are trying to find, creative ways that we can help spread information that we think may one day, might save somebody's life. We also have our kind of political channels there. We are starting a space that looks at the economy, because I think, nothing really moves without money. And health is directly impacted by your economic well-being. And so to kind of leave that out, we think would be just do our our community a disservice. We are a pretty small team. There's less than 15 of us. And we are very ambitious and we're trying to do a lot. That's why you're seeing a lot of moving parts right now, but we're getting into our stride. The Labora Rounds is going to start being released as early as tomorrow. And we can expect almost daily drops, given just the amount of of research and stuff that we're doing. And then we'll provide a weekly digest. Because the research takes some time, obviously, the research takes time to do, and then we have to do our own kind of vetting, cross referencing and compiling. We're going to be providing updates about 2 weeks back. So today I have like the most recent news, capturing the last week. But in general, we'll be publishing around about 2 weeks back to give us the time and opportunity to do some of that, diligence. Tisha, did you want to say anything?
Um, well, if someone new is joining the live, um, where would you suggest they start first when it comes to your Substacks?
Oh, if you are completely new, I would start with women's health. That's by far where we have the highest density of material. I I think in her name is a lot of fun. It's definitely it's a very honest channel. Let's just say that we try to give our honest opinion. Um, and then the blueprint is probably the most is the our newest kind of development. Um, but it's going to pick up pretty significantly because we have two um, big things that we're releasing. So labor rounds, and then also doula's corner, which should be, hopefully, we've heard from lots of doulas about, needing support and resources to not, because inevitably they live at that intersection between, you know, medicine and the rest of the world. And they're like the person in the room when patients are having to make these decisions, and inevitably they're patients are going to turn to the doula, right? Like that's just human nature. And so we want to empower them with information that we think everyone should know. Just like we can provide signs and symptoms of what does it look like when someone's having a heart attack, right? Like everyone probably can rattle off to me like the symptoms or the symptoms of a stroke. They're like on poster boards, and it's a part of our our lexicon that we don't even really think about it, but that's medical information, right? And there's no reason that that obstetrical complications, at least from a very high level, cannot be the same. Like everyone should know, some basic warning signs that a pregnant woman is an extremis, and we want to make sure that we're helping to provide that information as much as possible. Um, all right, so let's see. Okay, right. Did it come up? Okay. So we're going to start with our kind of first kind of segment, I guess, called This Week's Signal. Before we dive into the details, we want to take a step back and look at all 10 domains together. There are several like patterns emerging with regards to what's happening in women's health. So this is a time where science and scientific advancement is colliding directly with political obstruction. Um, Definitely, I've never seen anything like this in my lifetime, to say the least. But it's as if, you know, a lot of the things that we took as sacred in terms of, rational thinking, leading a society, leading your government, like, none of that seems to be true anymore. And so it's essentially creating a two-tier system where, geography unfortunately determines health outcomes, and where innovation can reach only those who can afford to access it. It is without a doubt the case that health inequities are going to get worse over the next, several years, to, hopefully limiting this period of time to, let's be hopeful and say less than a decade. But you know, we know what's going to happen when you turn away from science. The outcomes are predictable. So, so this week, the FDA made a historic announcement, removing warnings from hormone replacement therapy, which is amazing. There was, several important studies that were released. I want to say like 2 or 3 weeks ago at this point, around HRT and the benefit for perimenopausal women. That the health benefit is actually greater before menopause, which is was really kind of mind blowing. We're going to be presenting some of that information because I think it would be of interest to folks in our community. But this is kind of piggybacking on that. And so this is a correction that is 20 years in the making. This black box warning has left millions of menopausal women suffering unnecessarily. Um, at the same time, we saw the first generic Premarin approved in over 30 years, which is amazing from a cost perspective. So that's on the innovation side. But on the restriction side, they've also been quite busy. So the Wisconsin Supreme Court is debating whether an 1849 law written before women could vote, before the Civil War, before bloodletting was considered outdated, to determine 21st century medical practice. One justice called it evidence of a world gone mad, which it kind of feels that way. Like, you have to do like constant reality checks and say, yep, this is really happening. Meanwhile, the incoming administration has laid out plans for the most comprehensive assault on the women's health infrastructure in modern history. If people do not know what's happening, and how, women's health is being gutted, you know, this is why we're doing this, so we can keep everyone up to date. Um, so we're talking, 170 billion for immigration and for enforcement, while simultaneously stripping healthcare from, about 12 to 17 million Americans. We're talking 2,400 CDC positions just eliminated, including the entire team that updates contraceptive best practices, because it's just birth control. But the paradox is this: we have more treatment options than ever before and less ability to use them depending on your zip code, your income, your immigration status, or who controls your state legislator. That is what Labor Rounds is built to track. We want to not just follow headlines, but show how things connect, how policy becomes practice, how economics become access, and how innovation can either serve to close or widen gaps. Um, we're going to start now looking at some of our clinical updates. We'll get dive a little bit deeper into the HRT story. Let's see if this, okay, perfect. So, so this is probably the most significant clinical development of the month. The FDA announced that they're removing this misleading black box warnings from hormone replacement therapy products. So, if you've been in practice for a while, you remember what happened in the early 2000s. The Women's Health Initiative came out, it was misinterpreted, and suddenly HRT became synonymous with cancer risk. Anytime you talk about hormones with a woman, with a patient, this is going to be a subject of discussion because people are scared. They're scared and they don't know what is real or and what is false, right? And it's it it had because of that black box warning, it was very hard to counsel women. Particularly if they were very risk adverse. Everything in medicine has risk and benefits. That's how I always start my counseling, right? Walking across the street has risk and benefits. You can never die in a plane crash if you never get on a plane, but then you can also like never visit your family across the country. And so we take calculated risks all the time. And medical decision making is very similar to that. Um, for the HRT story in particular, the problem is we just didn't have the right proportionality to help women make that decision in like a reasonable way. And so yes, like the data had shown that there were increased adverse effects, but they were on par with things like having a glass of wine every day, right? So it was not only has the data been is now different and even more reassuring, but even looking at that same data, it just wasn't contextualized appropriately. And so the result of that were millions of women were left to suffer through menopause symptoms unnecessarily. Um, so this is what HHS Secretary Robert F. Kennedy Jr. and the FDA Commissioner Marty McRae announced to over 200 attendees, including the Second Lady, Usha Vance. Estrogen is a key hormone for women's health. Every single part of the woman's body depends on estrogen to operate at its best, including the brain, bones, muscles, and heart. And so here is the practice implication. So we're going to need to update our patient education materials. But more than that, we're going to need to spend time really deprogramming patients who've internalized decades of like fear mongering and messaging about the dangers of HRT. And we want to make sure that we are acknowledging people's appropriate fear, um, but also again putting that into context. Of course, this is not for everyone. You need to talk to your doctor. There are some women that this is still very much contraindicated, and if you've had a history of a hormonally driven cancer, for example, women who have had personal histories of like blood clots. They're people that you don't want to give this medication to. But there are a lot of women who have had benefit and will hopefully more will continue to benefit from this change. Also, kind of in tandem to that, Premarin, which is a generic version of one of the most prescribed HRT medications. Uh, it's been historically very cost prohibitive for women without robust insurance coverage. And so a generic means potentially thousands of dollars saved annually for women who've been rationing or avoiding treatment entirely because of the cost. And additionally, this matters for patients with contraindications. The FDA approved a new hormone treatment for moderate to severe, or sorry, a new non-hormonal treatment for moderate to severe vasomotor symptoms, just really underlying that options are really expanding.
Dr. Connor, I have a question.
Yeah.
Okay, so when you are speaking about the Women's Health Initiative study and it got misinterpreted, what do you mean by misinterpreted? Like language, no follow-up on information? What does misinterpreted mean?
Yeah, so the way that they were actually analyzing the data was inappropriate. They were looking at the patient populations without the right comparison groups. And so, the only thing worse than like no data is bad data because it can really lead you astray. And that the, you know, the data that people are really, that all of this fear is based on is the data that shows all the negative effects of estrogen. So, particularly the cancer risks, but also, other negative effects. And subsequently, those studies have been, re-examined, and more data has been added um, to, to the cohort, which have, allowed us to reinterpret it and have found that there's actually a lot of protective and helpful health benefits from estrogen. Not to mention the symptom relief of the vasomotor symptoms, because it works better than a lot of things that people who want to, before, like this, the new class of a neurokinin inhibitor. I think it's, I don't want to misspeak. There's a new class of non-hormonal medications that affect vasomotor symptoms. But before that, it was really, there weren't really many options. There were over the counter things. There were, non pharmacological, you know, supplements and stuff like that that people could take. But if those weren't effective for you, there were really limited options. Okay. All right. So, next big update is about the midwifery model. So, I think this is really important to highlight because the data is supporting what we have been observing, is that this care model is safer for patients. Patients do better. Um, so the Strong Start for Mothers and Newborns initiative continues generating compelling evidence that midwifery-led care models produce significantly better outcomes. So lower preterm birth rates, reduced cesarean sections, higher patient satisfaction, all while generating substantial Medicaid savings. I think this is a real indictment on the obstetrical profession. And yeah, I mean, I think I don't know. I don't know what else to say, but like, I think that the data speaks for itself. Um, you know, birth centers that follow the AABC standards routinely provide services considered enhanced in traditional settings. So doula support, breastfeeding education, nutrition counseling at no additional charge. And so reimbursements rates are only about 50 to 85% of hospital rates, despite superior outcomes. And so they're a lot, birth centers are a lot more holistic. We know that, right? So this is what is important to challenge. So this isn't about serving only, healthy white middle class women pursuing natural birth. 2014 birth certificate data shows women with midwife attended hospital births are demographically similar to those with physician attended births. And so birth centers specifically serve 23% of non white women, and Strong Start participants face considerable medical and psychosocial risks, including diabetes, hypertension, housing instability. So all that is to say is these patients, these were complex patients as well. They weren't all like, completely healthy, because that's going to be the first thing a physician's, you know, is reflexively going to say, that we have sicker patients. And in some practices that might be true, but it's not universal across the board. And the model works because of relationship building. The 30-minute visit, holistic care. This isn't about, patient selection. And we've actually paid a lot of attention to the data around, the health outcome benefits of doulas and midwives. And that's directly how our obstetrical model came to be, our emergency model came to be, because that's our underlying hypothesis, right? Why are there less, why do patients with, for example, a doula attending their birth, like why do they have better outcomes even if they have a hospital birth and everything else is like the same? I think because you have someone in the room who's there advocating, who's there to say, wait a minute, something's not making sense. I need you to say that again. Excuse me. And or someone in the room to say, hey, like something's not right, we need help now. And those things make a difference, especially on a busy labor floor, because it's rare. Obstetrics is not complicated. It's we have a very limited bucket of things that we deal with. And so when these like bad outcomes are happening, it's often not because we don't know what to do. It's it's because we fail to act. And the question is, why are we failing to act, right? And that's what our emergency model is designed to try to help prevent, is really force the system to act when it might otherwise not.
Dr. Connor, why, in your opinion, do you think there's such a disconnect with birth workers? I feel like, based on the numbers, birth workers help save lives in many ways. So why do you feel like there's like a disconnect on the level of care? I feel like the last maybe 5 to 7 years, we're just now really talking about doulas and midwives, but they've been around for centuries. So why do you feel like there's like a disconnect or a gap when it comes to that type of level of care?
Yeah, I mean, it's because of physician culture. Honestly, how do I say this? Um, and that this is speaking as a physician, so I'm not trying to disparage, people, but it's a very paternalistic, you know, profession. Um, Historically, it at least has been. The doctor is like the person that is right. I also think people forget that OBGYN is a surgical subspecialty. And so we have some of like the toxic elements that come with, you know, being a trained surgeon. That honestly, I think it makes people, it, it makes people not as like, psychologically and that, able to really care for people. I don't know if that's like too big of a statement, but I mean, a lot of people people are caring a lot. Let me just say that. And there's a lot of trauma in our specialty. A lot of the providers themselves have, trauma. And it is a specialty where, you know, you're like trained to kind of suck it up, right? Like, it's like, why are you tired? You've only been up for like, 45 hours. Like, get it together. Like that's how we train people. I will never forget this when I wanted someone to page me. This is when I was training. I wanted someone to page me because my phone was dying and the power had gone out in the power had gone out in my house, but I had my pager on, right? Because I was on call. And what they suggested is I go and sit in my car and like charge my phone. And I'm like, but why? Like I mean, first of all, I have kids. Like I can't just like abandon my children and just go sit in my car for no reason. But but why? Like I have a pager. Like this is why we have pagers because they work even if the electricity doesn't work, right? And um like if I really needed to call someone, I can then go sit in my car and charge, if someone pages me, I'll go sit in the car and charge the phone. But like I'm not gonna just go and do that, right? So there's just a lot of expectations of people like to sacrifice so much. That's a really long-winded answer to to say that you can only give people what you have yourself. And so if you are so so depleted, I think it just makes you a very bad practitioner. Just that simple. And the way that that manifests is, you ignore people, you minimize them, um, treat people like they are dumb. You are condescending, and that doesn't you can't take care of patients well when that's the case, right? Because your patient is your best, like that relationship is your best clue to what's happening with them, right? They're going to be obviously, I mean, it's very intuitive, right? It's kind of a no, of course you're going to ask the person who's being affected, but there's so many doctors who like rely on like labs and imaging and all these other like peripherals, which are fine. They're great adjuncts, but the thing that's going to make you the thing as a clinician, that you rely on for diagnosis is the patient. Like the patient will, because I can have a lab that's normal all day, but if someone looks sick, there's something wrong. Like we have to keep looking, right? I'm not just going to say, oh, the lab looks fine, she's fine, like just ignore her. And I think too many people are just kind of they just are trying to get through the day.
So it's very layered.
Very layered, yeah,
Oh, okay.
yeah, very layered. And yeah, I think we have I think the data says it all though. And that's what we have to come back to. Like it's not about blame, it's just about looking at the data. And that is very clear. We're not doing a good job. I think there are obviously, I wouldn't be a physician if I didn't think that there was a role for physicians, but we have to be able to have an honest assessment on where we're doing well and the areas that we're, you know, failing. Let's see. To do. All right. Okay. Next. So we're gonna hop to our law and justice tracker. And we're going to talk about the 1849 law governing modern medicine. I love when history and medicine collide in such a very absurd way. And so let's kind of take a journey back in history. Um, so on November 18th, the Wisconsin Supreme Court heard oral arguments about whether an 1849 law passed when Wisconsin was a part of the frontier, when women couldn't vote or own property. Um, they want to determine if that law should dictate how doctors practice medicine in 2025. And so the law prescribes a 15-year prison sentence for anyone who intentionally destroys the life of an unborn child. So, yeah, 15-year prison sentence. Um, I have once talked to someone who believed that women who have abortions should face a death penalty, like absurd. So one justice called it evidence of a world gone mad, which I think is that's like so many things today. And this is what's really absurd from a legal perspective. Wisconsin has passed numerous abortion regulations since 1849, including a 20-week ban in 2015. So why would the legislature regulate abortion at 20 weeks if it already, um, you know, if it had been already completely banned? So the state is simultaneously arguing that abortion has been totally illegal since 1849, and simultaneously regulated at 20 weeks since 2015. And so the practical effect is that providers stopped all abortion services after Dobbs rather than risk persecution or prosecution under a law that predated the Civil War. And so Missouri voters approved Amendment 3 in November, enshrining abortion rights up to viability in the state constitution. So this is the same state that rushed to be the first to ban abortion after Dobbs. But here's what nobody tells you about ballot measures victories. Passing an amendment is just the beginning. Missouri still has dozens of restrictions on the books: 72-hour waiting periods, mandatory counseling with medically dubious information, onerous facility requirements designed to shut down clinics. All of these are now facing legal challenges. All of them will take years to resolve. Texas is at it again. It's attempting to force New York courts to recognize its legal judgments against New York abortion providers who treat Texas residents. So, you know, this is a big deal. You know, because of federalism, the states have a lot of sovereignty. Like that's literally, up until like 2 seconds ago, that was literally the Republican Party's like central message around everything is that the states have supremacy in so many domains, but not when it comes to abortion. And so, if you think about it, a New York doctor practicing legally in New York, providing care that's legal in New York, can face prosecution from Texas. It's absurd, right? It's absurd. So shield laws in states like Massachusetts, New York, and California are supposed to protect providers, but their effectiveness remains untested against aggressive interstate prosecution. And providers are reporting a chilling effect, many refusing to treat out of state patients, despite the shield law protections, fearing prosecution if political winds shift. And so, what is the practice implication? If you're now practicing near state borders, you need state specific protocols and referral networks now. So, some providers are using separate encrypted systems for sensitive information that could be subpoenaed. Documentation strategies must balance clinical thoroughness with legal protection. So, that's one thing that we have some resources for people on that, but the way you document in this day and age needs to be very precise. And I think doctors are just not thinking about that because people are busy, they have a million things to do. But it can it can unfortunately have like significant implications, especially as things, the Republican Party becomes more and more deranged the closer we get to midterms. All right, so let's talk a little bit about the economy. So there is a hidden tax on reproductive care. So let's walk through what abortion actually costs in 2025. Um, and this is not just talking about the procedure. So, a woman in Texas who's seeking an abortion at 8 weeks might pay $500 for the procedure in New Mexico. But then, you add on, the $200 for gas or transportation, 150 for a hotel, mandatory if there's a waiting period, 100 for childcare. 60% of abortion patients already are mothers, and then $300 for lost wages. And so suddenly that $500 procedure becomes $1,200. So that's equivalent to a month's rent for many families. And this is intentional, um, to to put poor women into a box, right? Um, these economic barriers function as effectively as legal bans for a lot of low income women, because it's not going to be affluent women who are going to be constrained by these abortion restrictions. Like, they're going to find a way to get to terminate a pregnancy if that's really what they want to do. It's about the women who have limited options, and those are the women who practically also are going to be impacted the most from an undesired pregnancy. And so it's hurting them kind of coming and going. um, we know that Medicaid is collapsing. So Medicaid covers about 19% of adult women and finances 41% of all US births. In the South is much higher. I think in Louisiana it's like 60% of all births. It is the de facto maternity insurance for America's working poor. I have conversations every single day with patients about getting on Medicaid. Like, it is something, a part of our daily conversation, because a lot of people don't have health care outside of that, right? And so they're pregnant, so now they have health care, which is allows them to access these services, whereas before that wasn't something that they could do. Um, and so, let's see. So the post-pandemic unwinding has disenrolled over 25 million people since March of 2023. And a lot of this has to do with procedural reasons like paperwork errors, not because people aren't qualifying, but, to be on any type of, people act as if getting government, like subsidies is like some fun thing. Like, somebody would choose that if they had another alternative. It's cumbersome. The system is designed to make you frustrated, to waste your time. It's designed so that if you tried to like have a job, they will make it as hard as possible to actually be able to keep that job and also be able to keep your benefits. It is a twisted system, to say the least. Um, and so, for women, 44% of low income women rely on Medicaid. 52% live below the poverty line. And these, aren't abstractions. These represent women choosing between prenatal vitamins and groceries, delaying mammograms due to cost, rationing birth control to stretch prescription. And so this creates, a two-tier provider crisis. So large employers, Fortune 500 companies, are now offering travel benefits for abortion care. Their professional employees can expense flights across state lines for care. But a retail worker, the home health aide, the restaurant server in the same restricted state has no options. Abortion funds, heroically trying to bridge these gaps, report demand exceeding supply by 3 to 1. So average grants are between $300 to $500 when procedure and travel costs often exceed $1,500. it's heartbreaking to have to be able to triage who gets help and who doesn't. And so we are ignoring really important economics. Every dollar we spend on family planning saves Medicaid $7.09. So it makes sense to give people access to contraception, but we don't do it, right? So not only are we taking away the actual funding itself, we are also taking away the tools that would help everyone in the system. And that's how like twisted and convoluted this entire system has become. Each maternal death costs an estimated $8.7 million in lost productivity. And so we are paying more for worse outcomes. And that is just getting more and more true in this country. Um, I know it's getting kind of late. I don't know if you need to go, Tisha, or if people are still there.
We have 9 people in the chat.
Okay.
So people are trickling in.
Okay.
But this is good information, so I'm staying.
Okay. All right. All right. I'll keep going then. I'm a talker, so I can keep talking. All right. So couple things. So we're going to be talking next about, just to kind of give people a preview. Uh, we're going to be talking about the Comstock revival and the global gag rule that is returning. And if you don't know what that means, we'll explain it. And then we'll have a segment on immigration and reproductive justice. And then we'll end with just a little information about our Doula's Corner launch, and then we'll be done. Um, Forgot that slide. Okay, I think that might be the end. Okay. Um, I don't know if I have any more visuals that are worth showing. Okay. Um, so let's see. Okay. So we all know that the Trump administration is doing everything it can to make the lives of women as hard as possible. And research is no exception to that. So people are calling this the most comprehensive assault on reproductive rights in modern American history, and it definitely feels that way. It's not just about abortion. So the way this is not about life or any of those other explanations people give you is they're not stopping there, right? Like it's not stopping at abortions, and there's no work going into helping women live better um lives so that they're able to like better care for their children or make better, I mean, whatever argument you want to say, like none of those efforts are being made, right? What's happening is the system is trying to control women more and more, because that's always been the point. um, because it is clear that in order for these authoritarian projects to succeed, women have to be oppressed. Otherwise, it doesn't work. And this has happened throughout history, right? Right now, I like to think of women as like the last standing institution that can really put pressure against a lot of the forces that are, shaping our politics today. Um, I mean, you see it all around you. You see women are coming out and fighting. They're not scared. Because we have too much at stake. And I don't know, like, I want to say they're not scary because they are evil. But they also look weak, right? There's a weakness to this, to what's happening, that is empowering. And I think they recognize that, if they don't oppress women more, then their project is not going to work. And so, so what are they doing systematically to hurt women? So they're cutting NIH women's health research. Women and families are losing health care. You have a outrageous amount of money going into immigration enforcement, causing chaos throughout this country. Um, we have friends here I live in North Carolina, and they were supposed to come visit us, and they couldn't come visit us because ICE was in their building and they couldn't leave their house. Like, this is real. Like, their parents have already gotten deported. Like, they had to be in a facility, for weeks. Like, we didn't know where they were. We, like, they don't tell you this stuff, but like, we were giving money because like they don't really feed you there. Like it's horrible. This is inhumane. Um, we're like the richest country in the world, and we're treating people like less than human. And it's unconscionable, honestly. And then, of course, like, the CDC is being decimated. So the CDC cuts include the entire team that updates contraceptive best practices and the assisted reproductive technology surveillance unit. So what is that? That is the unit that makes sure that that your REI is not doing something crazy. This is a very specialized, technology. It's a very specialized part of medicine, and like anything else, it needs to be regulated. People need to have their eyes and ears open. And that's really the function of the government, right? To do that high level surveillance and keeping us safe that no one individual can do. And they're just gutting all of that, despite the claim that they love IVF. I mean, there's just so many things that don't make any sense about their love for IVF. Not to mention the the number of embryos that get destroyed, right? Like, that's a part of the process. So it's like completely just like, you can't, there's no way to square this circle, right? Like, there's no connection, right? You think an IUD is bad because it's a abortifacient, but then you're okay with IVF. It just makes no sense. And so the Comstock revival, I people have probably heard this in the news, that the administration plans to reinterpret the Comstock Act. This is a 19th century law that, again, was passed before women could vote, and it criminalizes mailing abortion medications or anything having to do providing abortion care. And so, no need for Congress, when existing laws can be reinterpreted to achieve the desired outcomes. So, executive orders already drafted for day one include, rescinding Biden's protections for reproductive health care access, reinterpreting the Comstock, to criminalize mailing abortion medications, directing the DOJ to abandon defense of emergency abortion care under EMTALA, and pressuring the FDA to revoke mifepristone approval despite its 25-year safety record. And so, it's just a calculated assault, one after another. It, you know, we're spending a lot of time looking backwards, which also has the unintended or maybe the intended consequence. Like, we're also not making any progress, right? Like, think about what we could be doing with this time and energy. Think about us here, like what we could be doing on this call today, instead of, we could be, working and providing advanced, like giving updates on advancements in science and all the great ways that, people are trying to help women live better lives. But instead, we are going backwards. And that's the thing that to me is, it's hard to like, scale this, but it's just so much, there's just so much tragedy here. Um, the last part of this segment is the global gag rule is returning and it's expanded. So the global gag rule, for those who don't know what that means, it is a rule that the U.S. government puts on like international organizations that accept U.S. Funding, that essentially prevents them for talking about comprehensive reproductive health care. So they can't talk about abortions, even with their own funds, independent of what the US government provides. So just by receiving this funding, you aren't allowed to talk about abortion care. And so what that means is that organizations that provide HIV treatment, malaria prevention, or maternal health services must either abandon abortion care entirely or lose all US funding. And so every like Democratic president will always rescind this, and then every Republican president brings this back. And what this leads to is clinic closures, contraceptive shortages, and paradoxically, increased abortions in affected countries. And so millions of women globally will lose access to basic health care because of US domestic politics. And the thing I think people also don't recognize is women in the US benefit tremendously from these dollars abroad. And let me tell you why. Because women's health is so underfunded in this country, a lot of the innovations in poor countries, right? They're developed there, they're refined and, you know, um, and then brought back into this country in order to, provide care to women in rural and poor areas, right? And so we are not only hurting women there, we're also hurting women here because we're not going to benefit from the work and the like the honestly development work that's happening around the world, in especially now that the US has like abandoned its its commitment, to women's rights or women's health, everywhere. Um, so last thing, is this is from our immigration and justice report. Um, immigration is, you know, it's definitely in my lifetime. This is, you know, this is a time of great like shame, and I don't know, like it's almost like you don't recognize the country that you call home, right? Like the things that were not supposed to be possible here, like the principles that we prided ourselves on, are just being abandoned. And the healthcare facilities are no longer a place where women are protected. And so this is what providers are reporting on the ground. And I told people this months ago when I put out a post, about law enforcement on in our in on our unit. I practice in some areas in rural North Carolina, and law enforcement is comes there, and it it was before it was clear what was happening, but it felt like this was a precursor to like what we're seeing now. And so, despite official policies designating hospitals and clinics as sensitive locations where enforcement should be avoided, ICE agents are stationing themselves in hospital parking lots, following ambulances to emergency rooms, and surveilling clinics serving immigrant communities. And so, what is the effect? Pregnant women are missing prenatal appointments rather than risk identification. Parents are avoiding vaccinating their children. This is leading to increased disease outbreaks, diabetes, hypertension, cancers. Like all of those diseases are not being managed. Women in active labor are begging to leave hospitals before giving birth, terrified that records will alert immigration authorities. And so, when pregnant women avoid prenatal care, what's inevitably going to happen? Maternal mortality is going to rise. When victims cannot report crimes, what's going to happen? Perpetrators are going to act with impunity. People are going to commit crimes, right? When families fear hospitals, children are going to die from preventable conditions. This is just logic. And we're just walking down this road without like any end in sight. There has been 45 billion of that, I think 137 billion that has been allocated for new detention facilities, including family facilities where pregnant women and mothers with children are held. And so medical care in these facilities range from negligent to actively punitive. I mean, it's just like really sick to even think about it. So pregnant women are being denied prenatal vitamins because they're considered non-essential. They're forced to drink contaminated water despite pregnancy risks. They're being shackled during labor despite policies supposedly prohibiting this. And pain medication is routinely being denied as drug seeking behavior. There's also pressure to relinquish parental rights to avoid babies being placed in foster care. I mean, this is unconscionable. And so this is kind of the truth that we have to confront, that reproductive justice is not possible without immigrant justice. The reproductive justice framework, the framework developed by Black women, recognizing that choice means nothing without access, provides the essential analysis here. So for immigrant women, the right to have children requires immigration status protecting against family separation. The right not to have children requires access to contraception and abortion, regardless of documentation. The right to parent children in safe environments requires protection from detention and deportation. And so, this is, if you care for women, this is your fight, right? This has to be one of the areas that you're active in. If you're not educated in immigration policies, then you need to learn. We're creating a lot of resources for people on how to provide guidance to your patients or communities that you serve, because we can't avoid this. This is going to be our lives, right? Um, and we know that until all women can make reproductive decisions free from state violence, then reproductive justice remains unrealized. And so, ICE, abortion bans, the Republican Party, the state legislature, all of this, all of these forces are making it so that women cannot freely like live their lives, right? To any meaningful extent. And while that's true, um, you know, it's upon us as birth workers, as people who support pregnant women, um, to continue to fight on their behalf, especially for those that don't have the ability to fight for themselves, because the system has oppressed them, or doesn't even consider them, doesn't even give them like the most basic of human rights, which is tragic. So, kind of the last thing we'll talk about is Doula's Corner. We talked about it a little bit in the beginning, but Doula's Corner is a dedicated space within the Labor Collective that is designed for the unique challenges doulas face. And why this is important, doulas operate in a very specific professional space. They're not clinicians, but they're deeply embedded in clinical environments. They're not policy advocates, but policy directly affects every birth they attend. You need the same intelligence we provide to midwives and clinicians, but framed differently. And so that's what Doula's Corner tries to provide. We work to give practice specific translations of our weekly intelligence briefs. We provide resources on scope of practice, legal protections, when to refer. Um, we provide direct, education around different medical conditions. And then also a business sustainability guidance, because when you become a doula, you essentially become a business owner. And it's very hard to be a practicing doula. Not only do you have to practice your trade, often you don't have backup. You're on call all the time, and then you have to actively run a business. And so we want to help provide resources to make that more sustainable. I believe, and our organization believes, that we're not getting out of this birth crisis without more doulas. Like, it's just not going to happen. There's literally the numbers. There's just not enough people to care for the number of pregnant women over the next couple of years. And so we're going to need all hands on deck. And that's kind of why we're building these resources in anticipation for that time. So Doula's Corner is included in the Blueprint subscription. And when you join the Labora Collective, again, everything kind of comes together. So that's it for today. Deep breath. Thank you, everyone, for coming. We want to let you know that we support you, we see you. If you have questions, please don't hesitate to ask. You can send me a message directly, or any member of our team, and they'll make sure to get it to the right person. If you want to see something different, we want feedback. Please let us know. We're again actively growing and shaping what this is going to be, and bringing other leaders and advocates and patients into the space to also help provide resources. And so we're super excited about our next steps. Hamza's gonna, if I don't show this, he's gonna say why didn't you show the Black Friday thing? So I'm gonna put this on. Okay, yes, perfect. All right. So we're offering a 30% off Blueprint subscription. The subscription actually gives you access to the entire Labora Collective, not just the Blueprint. And so you get access to Women's Health in Her Name, the blueprint, obviously, and then all of the kind of subsidiaries under each of them. And so the birth worker brief, doula's corner, labor rounds, and then kind of the other things that we are actively working to develop. All right, and that is it. Any questions?
Um, no, I think it was pretty straightforward.
I want to find a format that's like more interactive. I want to do some thinking kind of around that. I don't know if you have some thoughts.
Well, you're still on Substack Live, so is the I
Yeah,
don't know if you um
yeah, no, yeah. See, so that they can see where we're shaping in real time.
I mean, all this was such good information. And I think if we could somehow get the message across that healthcare is political,
Yeah,
would kind of help, bridge the gap. And I think you
yeah,
kind of you kind of alluded to how important it is when one part of the ecosystem collapses, it's going to trickle down to everyone else. So
right,
you may not feel like it's going to happen to you, but it can happen to your daughter, it can happen to your grandchildren.
right.
It's like this trickle down effect that it is political, and a lot of people want to stay away from politics, but you can't when it comes to women's rights and our
Yeah,
bodies and things like
yeah,
that. So if we can kind of
yeah,
figure out bridging the gap on how important politics and healthcare is, I think we
yeah,
can help a lot of people, kind
yeah.
of make sense for everyone.
Yeah, yeah. No, that's a good point. I mean, it took me some time to like feel comfortable because again, like that's physicians are trained to kind of stay in their lane, but it's absurd, like you said. Like it would be like, you know, there's like this, I don't know, this axe murderer outside the door. I refuse to like look at them because like that's not my job, right?
Hmm.
It just doesn't make any sense. Especially in this day and age. I honestly think you can't adequately take care of patients if you aren't aware that of what's happening in the world, and what's actively affecting your patients. And that's why we're providing these resources because it's necessary. And our professional societies are not stepping up and doing that, right? Um, not only do we need to have practice bulletins on like what are the latest medical updates, but also like where's ICE now, because that's going to affect where
Hmm.
like ICE is in Charlotte, right? Like that affects our patients. They're in the Durham, Chapel Hill, Raleigh area. This is important information that clinicians have to, all, and when I say clinicians, I don't mean just doctors, I mean people who take care of women in general, at all levels, have to have their eyes, and ears open. Otherwise, we can't effectively do our job.
Yeah, and I also um I would love for men to kind of support us as well. Um, I've talked to a few men, and a lot of them are just their statement is this is just a woman's problem.
Yeah,
We don't want any parts. It's a woman's problem. You you don't want autonomy over our it's a woman's problem. We don't want to deal with that, but it's very much so everyone problem when it
yeah,
comes to death, maternal death, and
right.
babies dying and things like that. I think if I would love for more men to speak out as well. For some reason, they're I don't know if they're afraid. I don't know if there's a disconnect. Um, I don't know. I think we have like a lot of women speaking out,
Yeah.
but sometimes I feel like it just falls on deaf ears
Yeah. You're giving me
for
an
some
idea.
reason.
I feel like that is definitely something can and should incorporate in like Roots and Wings or something.
Yeah,
Um,
I think it would be beneficial to a lot of people.
yeah. But like give men like an explicit invitation to the table. Like
Hmm.
because I think sometimes men also they don't know if their voice is wanted,
Yeah,
right?
yeah.
And so I think, giving them like, a seat at the table. They can't control the table, they can't run the table,
Yeah,
but you can have a seat, right? Like you can
right.
participate. You're an important part of, obviously, important part of women, the lives of women and children, and a huge holder of power in society. And so they have to be a part of the discussion. Otherwise, we're not going to be effective. So yeah, I agree. I agree like wholeheartedly with that. So we should definitely find ways of. I mean, we actually have a lot of men who support us.
Mhm.
Uh, so which is nice to see. But um, I would, I would be interested to see like a bigger cross section, right? Because the people who are coming to us are obviously coming because they want to advocate for women.
Mhm.
Um, but that doesn't necessarily represent like the average man's opinion. So
I
that
mean,
would be interesting to
not
see.
only not only that, but like, a lot of men are in these rooms while their spouses are giving birth, and they don't really know the signs either. You know, is the mother in distress? Who do I alert? Who do I need to talk to? Um,
Yep.
So I think starting there would be great.
Yeah.
They're not a lot of men feel useless in that
Yeah.
particular space, but
Yeah.
if they know like a call to action or a checklist they should be kind of going over in their head, they can
Yeah.
help they can help as well.
Yeah, no, I mean, and that's why like our pregnancy course is for couple. Like you get one registration and like two people. I mean, it doesn't have to be like just like a heterosexual male female couple. It could be any like two people, but the point is that if a woman's in extremis, like she's not going to be able to advocate for herself, right?
Mhm.
She might not even be conscious.
Yeah.
Um so you have to empower the support people, and that's an important part of the emergency model, right? Like
Hmm.
we have to we have to interact with men, because they're the partners who are supporting women, and like you said, like they need to know the warning signs, they need to know when to pick up the phone and say, hey, something's not right, and to
Hmm.
trust your intuition, and to not be scared of pregnancy. And that's another thing. Like,
Hmm.
pregnancy really scares people. Newborn baby. I mean, you'll be surprised. You'll be shocked. Even like in the medical establishment, it is insane. It's like non-OBs like don't want to touch pregnant women or babies. Like literally,
Hmm.
I remember there was a last time I was on call, we had a 24-week preterm delivery. And we're like all the way on the other side of the building, an L&D. So we're like running over, but we're like a good several minutes away. Because we have to bring like all the medical supplies and the carts and the
Hmm.
incubator for the baby, so we're taking some time to get there. And when we get there, the mom is still in the car with her seatbelt on, like the baby is like in her like in her pants, and we're just like, w like nobody like thought to like put her in a wheelchair and like wheel her in and cut the cord and like grab the baby, what do you think is gonna happen? The baby's not gonna fall apart. Like
Right, right.
it's a baby. Like it's like yes, it's delicate, but how is staying inside the mom's underwear for like, until the OB team comes? I mean, it sounds it's like so absurd. It's like it's like you could only laugh, but it's really sad, right?
Yeah.
Because I mean, this baby actually, survived. And but you always think like if we would have acted faster, if you would have
Hmm.
started the resuscitation faster, I mean, like that's brain, right?
Hmm.
Like that's like, especially for a baby that premature, like those seconds matter.
Yeah.
So it's everywhere. It's in the hospital itself. People just are scared of pregnant women, and that's something that we have to change. I mean, that's why I'm like so insistent of like everyone's like, oh, don't give doulas any medical info. Forget that. Like, forget that. I think that's just like nonsense, right? I mean, doulas. I mean, these women are smart. They're intelligent. They're not going to go and like try to do a C-section, right? Like, no one's going to abuse this information. Like, this information is going to empower people to ask the questions that they need to ask. And I just don't believe that women are smart. Like women know how to use information and how to contextualize it. And so I think that gatekeeping is again another way of controlling people, right? Like
Hmm.
that's all this is.
Hmm.
And we have to change that. We have to stop that.
Yeah, I'm with you. I agree. I've told you plenty of times before, I'm with the fight with you because it's been a problem, especially doing my own research and talking to different women and interviewing them. It's not. I wish it was an experience. I wish moms can have more of an experience
Yeah.
instead of horror stories and trauma-based care that they've had.
Right.
It's just a bummer.
Yeah. Yeah, no, I mean it's robbing women of like the joy of pregnancy, because pregnancy is a really special time. Wait, you have children, right?
I do not. I'm
You do not. Okay,
I'm an
there's a
aunt,
little.
but I
Okay,
was there.
that was your
Yeah, that was my
that was your
niece.
niece. Okay, so I was like, I definitely have seen a little girl. Pregnancy is a really special time. Like there's just nothing like it. There's a lot of negative things about pregnancy, but there's also a lot of really special things. And women can't enjoy that, right? Because of all this other just stuff, right?
Yeah.
All this other unnecessary things. And we have to work to change it. Like this cannot be the world we leave our daughters. Like that's like where that's where my commitment comes from. I have a 4-year-old daughter, and I don't want. I mean, this is not the world I want to
Yeah.
leave her. Right? A world where women are treated like property.
Hmm.
This is not okay. We know better. And the fact that so much erosion has already happened is, you know, we've already failed women. Let's just say that. We can't fail them more. So
Yeah. And I also think that I know my sister, she gave everyone a role. Um, I was the videographer. My sister was the ice chip person. The dad was the massager. My mom was just being mom. I think 'cause we all had a different roles in the room, and I think knowing the role kind of makes the experience better for the mom. I knew that my sister was going to be heavily drugged and she was going to agree to things that she probably not going to remember. So I think her wanting me there, um, she it was a trust. She trusts me and kind of communicating with her and the nurse and the physician on the experience. So I also think that the village is also important too
yeah,
when it comes to childbirth. Just everybody is a participant. I didn't give birth, but it was just a beautiful experience. Like, oh my gosh, like I was witnessing from contractions to coming into the world, that how
Yeah.
beautiful that experience was. And I was just glad to, to witness it and to support my sister during that time.
Yeah.
So I think, when it comes to pregnancy, I think everybody has a role and 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 should be willing participants in order to bring life into the world.
Yeah. Yeah. No, I mean, I couldn't say it better. I mean, it is a special, and you have to kind of like remind when you do this like day in and day out, you have to like remind yourself of like just the beauty and like the simple things, right?
Mhm.
Um, like seeing an uncomplicated like vaginal delivery is like, there's like a beauty to it. Like you started off with one person and now there's two. And the way that the body like changes almost like in real time, right? The
Mhm.
uterus goes from being bigger than a watermelon to you know probably around this big. Like it's just
Yeah.
all these physiological changes happen, and most of the time they happen right, and that's why we're all here. And just kind of stepping back and like bearing witness to that, I think is really important. Um, Yeah, I like I talk about my kids all the time. We're actually thinking about like, are we gonna have like one more kid? I'm at the end of my reproductive life, so I just turned 40 this year. So I will be. I think I'm like an elderly. I think like calling me an elderly like multi-gravida. Uh, but I don't feel elderly. But yeah, if we end up having another child, it'll probably be in the next like 1 year or so.
And
Um,
that's actually another thing. As we get older as women, what are our chances? Um,
yeah,
a lot of people mention that it could be risky. A lot of women
yeah,
have successful births. I think those conversations are important too. I think, well, as I'm 39, so I'm already getting the whispers of be prepared, your body's going to change again, or the perimenopause and the menopause, and uh, a lot of women have horror stories, but I don't think there's enough discourse and conversation when it comes to that part of your life too.
yeah. No, not at all.
Yeah.
For a long time, women were just expected to like suck it up, you know. But that's slowly changing. And we definitely want to normalize it and talk about it. Um, and if it's helpful for people, I'm happy to like to kind of share my thoughts on like my own pregnancy risk at 40 and kind of the way I think through it. And I think my partner and I, we wouldn't do anything to like I think we already have 3 kids. We're not going to do anything to like enhance our chances of conceiving naturally. And so it either will happen or not. I still like have an IUD in place. So knock on wood, not having any, um, surprise,
Mhm.
pregnancies. But, it's something that we're actively talking about. And there are real risks. We know that like the risk of complications are going to be higher. I had a postpartum complication after my last delivery, and we're still not really clear what happened. I'm pretty sure I had severe preeclampsia, like looking
Mhm.
back. Although like the diagnosis wasn't clear, I had like the worst headache of my life. I had like crazy blood pressures. I mean, that should have been enough probably to give me the diagnosis, but whatever. I also was febrile. That's the other thing that kind of confused people. Is I had like some systemic infection, and we like never really figured out what it was. Like I was scanned from like head to toe.
Mhm.
Um, you know, and they gave me like broad spectrum antibiotics and thank God for modern medicine. Like, I got better, and we might never know, but what that tells me is like I'm at some risk of having some sort of complication again. And just going into like the pregnancy, knowing that, and having honest discussions, I think is really important.
Yeah, I think your overall presentation today kind of spotlighted on how women are not having the ability to choose anymore.
Yeah,
Um, Women can have the choice to choose to have children, to not have children. I feel like the laws set in place now is ripping our right of choice,
yeah,
and it's it's frustrating.
yeah,
I'm not a mother, and I don't plan to be, but just because I'm not, I don't want to take that away from women who want to have children. So
right.
I think no matter what stage you are in your life, this is gonna impact everybody in some kind of way.
Oh yeah, 100%. I mean, that's why I think, you know, in in 10 years we're going to be having a very different discussion around abortion care, because everyone is going to know someone who suffered like some catastrophic outcome.
Yeah.
And that it's just so unfortunate that like that has to be the way that we learn. Um, but I don't think that this is forever, because of that, because the consequences are real and they're visceral. And I think if when people experience that, when they see someone that they love and like the doctor not being able to help them, I mean that's a terrifying and horrifying experience to be in. There's no other context in which you're ever in that situation where you're asking a doctor for help and then they're like refusing to help you. Like that's not an experience anyone else has. And the fact that we're subjecting pregnant women to that is just unconscionable.
Yeah, I think your initiatives will help give everyone valuable information. A lot of people don't know what to do because they don't know that the information exists.
Yeah,
And not only that, the other stresses of the world, like you were stating, economically and, wanting the basics kind of put things like this on the back burner because a lot of people can't even get basic needs right now.
right.
So, but I think the information that you provide in the research is always available for people. So I like the research part of it. I like
That's
to
good.
see the
I hope
progress.
people
Yeah.
I hope people find it helpful. We put a lot of work into it. And so I'm really eager to see how the reception is. And because we're going to continue to like refine it. Maybe the reports are too comprehensive. Like that's one thing I'm worried about. Like, are people going to have time to digest it? And so we're trying to, provide various like formats. So like an audio format, and then like an overview digest, so people can get like the big highlights. But I think something like this should exist, right? There's no go-to place to know what's happening in women's health. Like that doesn't exist, right? And that should exist. And so we're working hard to try to create that.
Yeah.
Um, so um, I think we are going to wrap up soon. What do you think? I'm tired.
For sure.
It's late over here. Uh, it's almost midnight on the East Coast. But thank you, Tisha, for doing this. I'm going on another call stretch. So unfortunately, we're not going to be able to do another one of these for a little bit. But, um, as soon as I come back, I'm excited to do more. And I know you have some events planned for people, so they should look out for more information.
Right, right. Thank you so much.
Awesome. Good night, everyone.